항상 아침을 봤냐고. 병원에 있죠?
Good morning. Welcome to this week's ECG conference. I'm Wasim Rashid, an International EP Fellow at Severn. And let's start with today's ECG.
Perfect. Leon?
Well, first it is tachycardia with about 150. I think it's the regular morphology. And this lead what? Yeah. 2,
1, 2,
3, AVRLF. Okay. 1 is positive and AVF is negative. So it has a left axis deviation. And V1 transition comes in V4 or 5. Looking for the P wave.
Okay, 5 seconds. Let's go to reverse direction, clockwise rotation. Oh, clockwise.
Clockwise is me. All right. So this is a regular rod complex tachycardia rate of about 150. It's about 150 to 160. There are. Follow the mouse. There are some. This is the rhythm strip. Yeah. So right. So over here, there seems to be a bump here. Probably another one here, another here. Here, the T wave looks different from the previous ones. So I think those are. I think there's some AV dissociation because the P rate is a bit irregular compared, like it's different from the V rate. There's a left axis deviation, and in lead V1, it has an LBB-like morphology, but I don't think it's a typical LBBB. Maybe a non-specific conduction abnormality. Intrinsic deflection time is also a bit sharp. It's not too broad. Putting it together, my first differential, because of the AV dissociation, will be a VT, but a close second differential will be SVT with aberrancy. I'm not very certain about the P waves because it's a bit blurred, but I think I put VT first with SVT with aberrancy as a differential diagnosis. And if it's VT, I think it's likely coming from quite close to the conduction system based on the intrinsic deflection and the fact that the QRS is not so wide as typically expected of it.
So VT or SVT?
VT number one,
VT number one.
and then
Okay.
SVT number two.
Angel?
Yes, actually it is about 150 yards drive area and the exit left axis deviation.
So just speak a little louder, bigger.
The V5 or V6 lead, as the copy mentions that after the QRS, end of the QRS, there is a small notching. It seems like not a constant. So I thought it is a VA dissociations. And
Sick.
in the precordial lead, it is the LBB pathology and we lead down and ABL if it is coming from the right inferior identical negative. And also the B4, B6 is so maybe like posters. And yes, I thought it is the BT number one, the BT, and we should differentiate.
Okay, can you the list of the findings which favors BT?
Number one, as I mentioned, for VA dissociation as we clearly see the V5 or V6 lead. And
Which one is a AB dissociation? Please, the followed mouse. Which one? You can tell, watch it.
the V6, there is a P rate notching after the QRS, end of the QRS, but it's not that constant. It is-
Okay. As the segmented, it's changing, right? So if there's the AB dissociation or VA dissociation, are you sure it is 100% VT?
Not 100%. But,
What is the exceptional case? Even though you see the VA dissociation, it is not VT. What is the exceptional cases? Of course, the probability of VT is higher. But if there is a conduction block or very fast atrial arrhythmia with not the one-tone conduction, yeah, it can be the AB dissociation, right? Even under SVT. Okay, Oingari?
I agree with all previous answers. So initially, I think I thought it's SVT, but I carefully see lead V5 and V6. I found some notching, and also I can see the fusion bit. I think it's easy fusion bit a little bit different from the other ones. It's like slightly curious. Then I also think secondly it's
Okay, VA dissociation
VA
and
dissociation.
fusion bits
fusion bits.
favors VT.
Yes.
Okay, and which findings against the VT?
That's not typical LDV pattern. It's like like pattern, not broadly. So maybe right, mid, going.
And intense coist deflection time is pretty sharp, right? Okay. Another comment? Anjipa?
I think this SVT. And because, as you said, morphology is not appropriate for the morphology criteria. And in the release rate,
seemingly dissociation might be equal in consumption of SVT because the rate is about 150.
So how can you explain the suspicious fusion beats Oyundari pointed?
Sorry, which one?
Example, this one. Really broader than.
What shape?
Do you want to see the baselines?
Okay, one more people, the Dr. Then let's go to the sinus rhythmicity.
I favor SVT with aberrant or fixed bundle branch block. Typical bundle branch block pattern. There is no definite AB dissociation, and of course, Oyundari pointed out the different QRS morphology. However, some other mechanisms can be involved except fusion bit.
Okay, I think that experienced doctors favors SVT, but the fellows favors BT. Maybe the coffee led some bias, or it's right. Okay, let's vote.
There's one group which favors that it's a typical LBBB and be SVT with aberrancy, and other group. So this is the
No. Come back. Oh. Okay, so let's vote. SVT. 3, 4. Oh, you changed. Oh, yeah, you didn't say that.
I'm
BT.
half.
And BT. Okay, 3 people. 4 to 3. Okay, please go ahead. Yeah.
We want to revise your diagnosis. So what are your comments on the sinus?
Okay, who will start? Let's start from Oyundari.
I can see sinus rhythm with about 5 beats per minute. And at the time, there is no delta wave and no short PR dual. And no, a slightly left axis deviation. And there's no specific. Yeah. No significant TV changes.
Minjong?
Rate about 75 at 8 moment. Yeah, well, 15 quite normal within the normal range.
I cannot hear you.
The interval of the PR or QRS QT is within normal range.
Okay, copy. Just to pick up the abnormal finding.
Okay, so I think the PR is a bit short. I think it's less than 120, and I don't know if I am creating it, but looking at V1, there seems to be a little pre-excitation. There seems to be a small delta in V1. I think AVF also shows it a little as well, but it's not very prominent. So I think there's some minimal pre-excitation with a short PR. Aside that, just a sinus arrhythmia.
So, like this medical pre-excitation, you like to advise the diagnosis with that?
Well, yeah, so then I'll move. SVT was my second differential, so I'll move it.
Go back. Yeah, that I cannot say there's some abnormal finding, even though that if we have biased eye, there's some little the minimal delta wave, but then I cannot tell you it's absolutely abnormal. Okay.
So many people thought this is a typical this white curves of cardio with typical LV morphology. If we go to Jackman's book, The Art of War, he lists these differential diagnoses to be considered in a patient with white complex cardio with typical LV morphology. First is HVT with LVs. So first is with aberrancy, like AT, AVNRT, or orthotomic AVRT with aberrant conduction. Yesterday only there was a case of LVV morphology tachycardia and turned out to be a concealed orthodromic AVRT from left side. So typical example. Second is a pre-excited AVRT using a atriofascicular or Mahim fiber for integrated conduction. Third is a bundle branch variant PT. Fourth is a pre-excited AVRT using a neurovascular XST pathway for integrated conduction. And fifth is a focal VT originating from the RPBV. So
we should list of those differential diagnoses, right?
Mm-hmm. These are the differential diagnoses.
Yeah.
And do you want me to reveal what the diagnosis in this patient is? Or do you want to just vote which ones do you favor among this list for this patient?
If you study or long-term monitoring. Yeah.
But she had so she was a 22-year-old female with recurrent palpitation for 2 years, very troublesome palpitations. She had a normally structural normal heart, and electrophysiology showed Mahim fiber tachycardia. But she recurred twice, and she had to go on the third procedure. This is prone to bumping, and during the procedures, it felt that everything had gone off, but she again came back with the same tachycardia. So since this was an ECG conference, I did not put the EGMs, but I just want to show this incremental A pacing. So this is a typical Mahim fiber behavior, where when you incrementally A pace, you get a pre-excitation. That is the HV, H moves into the QRS, HV shortens, but the AV interval prolongs. So there's a decremental conduction over the XSV pathway, and this XSV pathway only conducts antegradely. It does no retrograde conduction. So the tachycardia is basically a pre-excited AVRT, antidromic AVRT. So I kept only one slide just to show the Mahim fiber behavior on A pacing. That normal XSC pathway behavior is that AV will shorten and HV will also shorten, but Mahim fiber is decremental, antegrade conduction. The AV will increase, but the HV will shorten. So this is typical Mahim fiber decremental.
So was it dependent on pacing cycles?
Yes, it will. The LVB morphology increased as we increase the pacing. So just to prove that this was a.
Okay, so this is the exciting case, and now we should explain the AD dissociation like pattern and also the transmorphose a little bit. So anybody can explain that phenomenon we saw from the tachycardia ECG? Oh, Dr. Huang is here. I wonder if you have a tachycardia EGM. You didn't bring it. You have, but you didn't bring it. Okay. I hope see the whole story next time. It's an interesting case. What is the characteristics of a Maheim fiber? Copy?
Maheim fiber usually has decremental properties.
Hmm?
So at the tachycardia rates, there can be conduction VA or AV conduction block, and so that can give the impression of AV dissociation. Yeah, so perhaps what we identified as AV dissociation here is actually because of the characteristics of the Maheim pathway.
So Maheim is actually entry the decrement property by Pasteur, right? So the FAD is the irregular with LBBB excitation. It could be,
If people want to see the tachycardia.
me?
Uh,
No.
I have to connect with EGM.
Yeah.
Are the HDMI? Where's the HDMI cable?
Yeah, that's it. I think this case might be educationally very helpful. So presented in another
EGM.
conference, EGM conference or something. Okay. So we still need to differentiate. It is rate dependent on the branch clock or atrial tachycardia related excitation. So EP finding is definitely the looks like the orthodromic tachycardia, right? So trust me, I saw the EGM. Although the now we cannot show the EGM in the screen. So any other comments? We need to differentiate SVT, Maheim, SVT with aberrancy, and atrial tachycardia with Maheim, atrial tachycardia with nodovascular or other unusual bypass tract, and also VT. So we just try to differentiate VT or SVT, but there's more potential diagnosis based on the first ECG. Okay. Tom?
Oh, yeah. Nice case. Thank you.
Dr. Huang, are you there? Maybe not. He's in Myanmar. Okay, thank you very much. 이자들이 너무 많다 지금 기사들. Man, sick people.
Okay, I will start the EGM conference. I'm Min Jung-chae from Severance Hospital. This case is 82 years old male patient. He had a palpitation since 2 years ago. He had a history of persistent AFib and flutter and underwent the CTI ablation in 2020 and PV isolation in 2024 with cryo. And due to the sick sinus syndrome, he implanted a conventional permanent pacemaker. He take the carvedilol and digoxin. This was the last echocardiographic result. And this is the baseline ECG. There was no significant finding on chest X-ray. So we performed the EP study. This was the baseline catheter positions. We put the duodecapular catheter in the low RA to the CS and the decapular catheter to the high RA and the quadripolar catheter to the SVC. When we start the EP study, 81 was observed and the PP interval was 310 milliseconds. We trying to entrain at the H12 The PPI minus TCL was 227 milliseconds. When we entrain at the high RA 910, the PPI minus TCL was 69. When we performed the entrainment at 819 to 20, the PPI minus TCL was 159. When we entrained at the 878, PPI minus TCL was 205. And we trying to entrain at the high RA 12. When we start the entrainment, the ATR sequence was changed to the 82. The proximal part of the CS was changed. So 82 was PP interval was 275 milliseconds. When we entrain at the 817 to 80, the ATR sequence changed again to the 83, comparing with the 81 and 2. During 83, PP interval was 246 milliseconds. So we trying to entrain at the 812 during the 83, but again, the ATR sequence changed to the 81 again. So we performed the activation mapping. This was the result of the activation map of the 81. And this was the propagation map. As shown in the map result, the wavefront propagate downward and anteriorward and also activate the posterior simultaneously and goes up back to the SVC. We are trying to map the 82, but it was not that sustained and reinducible, and also it changed to the another sequence when we tried to map or entrain. It is the activation map of the 83. It is as shown in the propagation map. Comparing with the previous 81 propagation map, the wavefront propagate from the posterior lateral wall of the array, and it activates the anterior wall and ends up at the array lateral and around the SVC like a counterclockwise upper loop reentry. So we perform the SVC isolations, and when we put the grid catheter in the SVC, there was the long fragmented and low amplitude signal was observed. So we performed the SVC isolations while checking the phrenic nerve capture by pacing during the ablation. After RF, first ablation at the SVC during the EP study, 82 induced shortly during the rapid atrial pacing 200 milliseconds, but did not sustain. So we tried to reinduce, but it changed to the AFib. So we performed the second ablation at the low RA lateral wall near the crista terminalis. After the second ablation, AT was not induced anymore. And this was the post-RFCA ECG with sinus rhythm. So I bring some review about the upper loop reentry atrial flutter. The positive flutter wave in the inferior leads mainly suggests the three possibilities: the left and atrial flutter, upper loop reentry, and reverse typical atrial flutter. The left atrial flutter can usually be distinguished by its taller flutter wave amplitude in the inferior leads, reflecting a stronger inferiorly direct left atrial activations. However, when upper loop reentry and reverse typical atrial flutter often shows the similar ECG finding in the inferior leads, making differential difficult. So in this situation, the lead 1 is particularly helpful because its flutter wave polarity mainly reflects the left atrial activations. In reverse typical atrial flutter, the left atrial activation is direct toward the lead one, resulting in a positive flutter wave. In contrast, during the upper loop reentry, the opposite right and left atrial activation vector partially cancel each other, so producing a negative isoelectrical or even the flat flutter wave. So therefore, when the inferior leads are positive, positive flutter wave in the leads one favor the reverse typical atrial flutter, whereas if it is negative or isoelectrical or even flat, it can be a suggest of the upper loop reentry. So as you can see in the figure one, in the V1 lead, the A is the reverse typical atrial filter, and you can see the positive polarity P wave in the V1 lead one. But comparing with the A, BC is the upper loop reentry, and the P wave of polarity in the lead one is negative or isoelectrical or even flat. So the second study suggests that upper loop reentry develops because of a functional conduction gap within the crista terminalis. Due to the heterogeneous conduction property of the crista terminalis, the conduction gap persists and becomes the critical isthmus that maintains the reentry circuit. So in some patients, the right atrial scar also contributes by forming the central obstacle. Therefore, instead of performing a conventional CTI ablations, the authors targeted this conduction gap within the linear RF ablations. After ablation, the upper loop reentry was no longer inducible and no recurrence of the atrial flutter was observed. And during the follow-up, interestingly, the atrial fibrillation also disappeared in several patients, suggesting that this conduction gap may play an important role in maintaining the both upper loop reentry and AV. And this is the final.
I complicated the presentation. So did you match these emojis? Your case?
Wave in the period of the baseline mountain and the polarity of the P wave is quite isoelectrical or even flat as comparing with the typical reverse atrial. So that can be the clue for the differential diagnosis of the atrial flutter.
Can you explain the exact reentrance circuit of upper loop reentry? You already studied and reviewed a few articles, right? Xiancheng has original.
So in this case, you mean in this case?
Generally.
Generally, there is a I read that there is a two kinds of propagations that makes the upper loop reentry. Is one is the counterclockwise, and the other one is the clockwise. And in this case, I thought it is the counterclockwise, like starting from the posterolateral and goes up and also go down back to the anterior baseline, anterior to the crista terminalis. In this case, I thought the lower RA around the crista terminalis is the main obstacle for this case.
Is this single loop reentry then? If you look at the propagation like carefully, it's the big circle around the crista terminalis, right? But usually, generally, macro reentry shows figure 8. two circle. Okay, leading circle reentry is a very old concept, and if you carefully observe the reentry circuit, mostly they have figure eight. So if you can you repeat one? The other circle going around the SVC. Yeah. So that's the usual pattern of upper loop reentry. It's a sinus venarum and crista terminalis, because crista terminalis has a big, very high safety factor. Have you ever heard about safety factor? Safety factor is the ratio, conduction velocity ratio, longitudinal conduction versus transverse conduction. Isotropy, right? Yeah. But crystal terminalis, the safety factor is very high. Longitudinal conduction is very high compared to the transverse conduction. That's why and also it has a big obstacle. So that's why it could make a transverse conduction block and make a functional reentry. But there is another case. The case is who has a sinus venarum scar, especially old patient, and also the multiple ablation history. Those patients has a sinus venarum scar, also provide the macroreentry circuit. But always the other one, I cannot say always, but mostly there's another circle around the SVC. So you need to carefully observe the propagation map and point which area you need to, how to reduce your ablation energy. Okay.
Was SPC isolation important in this case, or could we have done just a line from the slope reduction? What are the IVC or SPC?
It's the operator's discretion, but I do not the circular SPC isolation, because several days ago I already told I have experience of SPC isolation in 91 years old man. And eventually, last point was fragment capture. So I just burned 20 seconds, and patient got 91 years old man got the fragment paralysis, and eventually he recovered. But afterward, I do not circular SVC ablation. Yeah, if you look at the color map, you see that there's another reentrance circuit at the SVC, right? So Minjung, initially you shows the 3 different AT circuit, but I could not follow you. You moved too fast. Can you estimate the reentrance circuit based on the left, right?
Actually, I want to ask you about how to guess based on the EGM.
You should explain it. I did. It is not my case, right?
Yeah.
What is that? So first of all, we have to determine if you have this kind of electron, you have to determine it is macroreentry mechanism or microreentry mechanism. If it is microreentry, just point of ablation, you can solve the patient problem. So how will you differentiate this macroreentry versus focal? Whatever is microreentry or the real focal?
By training.
The tachycyclines minus PPI did not match, right?
Yeah.
But during entrain casing, how do you determine it is macroreentry or not? Anybody? Constant fusion, progressive fusion? Yes, progressive fusion. Yeah. So we always measure the PPI minus T-share alone and see the active sequence. But if you when you start pacing, you should try to find out whether there is a progressive fusion. Okay, if there is progressive fusion, it is more likely macroreentry. So in our daily practice, we skip it quite frequently. So I wondered, can you review the EGM and whether there's progress fusion? Only you cut up the last point. Oh, what is the issue? You have a slide. You just start pacing.
Yes,
Okay.
I only had not in
Okay.
trained one.
Not captured.
Yeah, this one is not captured, and also the HR sequence is changed. But the other ones, I only put the end of the pacing.
So please review when you do entrainment pacing. Please review whether there's progress fusion or not. It is very useful way. If it is macro entry, the 3D map is very useful, right? There's, I had the argument with Hiroshi Nakagawa during live case. He insists that we don't need entrainment pacing anymore because 3D mapping is very beautiful and it gives us many information. And sometimes we saw the entrainment pacing change the sequence or sometimes terminate. So he insisted just to detail the 3D map. At the time, Rhythmia was introduced initially, but I think we can have many information by entrainment pacing. Still, it is very important. So I would like to listen to Dr. Ohm's experience. He has many patients with
technology proving so detailed 3D mapping can overcome the demerits of the and if we try to entrainment pacing, we need to start the just shorter than tachycardia cycle length and little bit shorter. So we need to prove the fixed fusion at fixed cycle length pacing and progress fusion when we shorten the pacing cycle length. And the other one is we need to compare the electrogram during pacing and tachycardia. So we need to differentiate the concealed fusion or manifest fusion. There is many manifest fusion. When you show in the slide you showed us.
which one?
For example, and at first we need to confirm the capture and acceleration of tachycardia, and then we need to compare the electrogram concealed fusion or manifest fusion, and then we need to measure the BPM and TCM. We skipped many steps before measure the BPM and TCM.
But as we saw in this case, if the patient has many structural changes, substrate, sometimes tachycardia, even the same macro entry, it changed their circuit. So that's why there's a really difference.
In this case, is it even capturing because the pacing spike is falling after?
Which one?
In this slide, is it capturing it?
I don't think so.
No.
I don't think so.
I would like to say one more thing. Can you show me the previous slide? Previous or yeah, that one. Probably you pace duodecal 17, 18, right? Then if you would like to entrainment pacing, then you need to set the sensing at pacing electrode, and then you set the delay as tachycardia cycling or zero. You pace over there.
Follow the mouse.
So any variation something. It's why tachycardia is changed to another tachycardia. This can be this pacing can terminate this tachycardia or change or degenerate tachycardia. So at first we says here why you said here. If you pace, you would like to pace here, then you sense here, and then delay zero. Then you can pace like this. Then you pace almost same timing or little bit shorter. Then you preserve this tachycardia in the pace. This is anti-tachycardia pace. Yes.
So you mean sensing electrode and pacing electrode?
Yeah, same.
Should be same.
Yeah.
That's very good point. Yeah. We just leave the pacing by the technician and the nurses, but we need to check it. I think Dr. Taehyung Kim is in. Taehyung?
Yep.
Please show us your face and it is your case.
Minjong, actually, I did pay.
Please speak louder. I cannot hear you.
Actually, I did pay at
No,
two
no.
different.
I cannot hear you. Anything.
Really?
He's muted.
Yeah. High risk of accident.
Oh,
Dangerous.
yeah. Taehyung, I think you're on during driving the concentrated drive. It's dangerous. Okay. It's busy now. Okay, so it looks like the entrainment pacing. My practice is multi-site pacing and estimate what is the circuit, and then high density 3D map is very useful. And please comparing the voltage map and the activation map side by side, because you need to define which area is the critical area and provide the functional reentry or the scar related fixed the substrate. I strongly recommend to compare the voltage map and activation map together and high density map. Then if you estimate which area is critical area, then change to ablation catheter at the probable site. And at that time, it's really careful mapping and entrainment pacing before burn. If it is really critical point, you will see the perfect entrainment. But at that time, as Dr. Om mentioned, you should sensing and pacing and the same ablation distance. Okay. Yeah, you can minimize the RF energy. And don't forget to trace big A reentry, both sides, not just one big reentry. And another thing I would like to emphasize, what you see is not everything, because even the atrium wall is thin, but it is three-dimensional structure, especially the crystal terminalis area, Bachmann's bundle area. High crystal ablation is very difficult. Some people, I dissected over 30 the cadaver heart. Some patient high crystal is floating from the free wall, like a myocardial bridging. So it is really difficult to make a conduction block. So you see there just endocardial activation pattern, but sometimes there's a missing point. And the epicardial conduction, you cannot visualize in the street mapping. So imagine how is the reentry circuit is going on. Okay, any other question? Let's go ahead. Let's see the 3D map. Okay, so where was the final ablation point? SBC. I think that area is a very dangerous area. I made a I had a bad experience of fractal paralysis. How did you pace? How much energy?
15. It was.
Hmm? You
15.
should know that.
10 volt.
Hmm?
10 volt.
10 MA is too high. Yeah, because the SVC is distensible structure. Even though it is away from the little away from the prime nerve, it can capture. So I usually follows Dr. Chen Huang's method, the original Huang, and he recommends 6 MA. Yeah, and slow pacing with 6 MA, and you move around catheter carefully and tag. Please tag which point was frame of capture area. Okay, then burn carefully, and during ablation you can keep pace. I think during my case, you put your hand on the patient chest whether there's a frame of capture or not. So if I think that Dr. Wang is thinking, oh, if we use PFA, it's
Why not?
simple and easy. Okay, so SVC and the lower part of the circuit. And do you have a voltage map here?
Can we make a line from this lower part of circuit to IVC and still terminate the tag?
It's possible, but it is extensible lesion. So that's why I would like to see the voltage map. Especially the patient. Oh, that is one. Can you blow there? I would like to see side by side with LAT map. Oh, don't change it. Okay, even though there is a low voltage area, but the edge is not complete scar, right? So it's better to limit the ablation energy, mostly the functional conduction block. But the patient with structural heart disease or the post-operative heart, there's some patient with big scar. At the time, as you mentioned, you can make a linear ablation, but as I told you, the right atrial free wall is paper thin. So sometimes you can make a complication. Also, the frame nerve. Can you imagine the frame nerve location in the right atrium? SB lateral wall to anterior direct. No. Frame nerve goes like this. But which structure is here? Here, that side. Vagus nerve. Yeah, I have a case because so we did the cable line study, and you saw that my SV receptor line is just upper limbus of fossa ovalis. But a long time ago, I tried to make a surgeon's cable line, and I have one patient after cable line, severe gastroparesis, lasted longer than 6 months, and patient was suffered from GI trouble and constipation for a long time. So posterior right atrial, posterior inferior part has a risk of the vagus nerve injury. Yeah. Okay. Any other comment? Question? Oh, no. Okay. Last thing. Oh, I'm talking too much today. When you ablate the right atrial pre-wall, please make catheter like this. Okay. If it's straightforward, if you push, you can, yeah, make a hole. So it's safer. But nowadays, because we have a contact force, it's easier, safer. But don't forget, the measurement by current modern technology is sometimes wrong. Okay. Okay. So if there's any other comments, let's go home and enjoy the weekend. Thank you very much.